And myomatosis is with the wall. Cholesterolosis with the wall. Same thing in the urinary bladder. If there's a cancer, it's in the wall. If it's a polyp, it's in the wall. If it's a calcification, it's in the wall. If it's the inflammation, it's in the wall. Then what is inside? Is the urine. Is there any pathology in the urine? Yes, you might see stones over there. So, we have to know this anatomy, that this urinary bladder has a wall, and wall has the maximum disease, like a gallbladder wall. And urine, that is inside the lumen, there's a minimum disease. And the wall has a diverticulum too. So that's why we need to know the anatomy of the wall. Okay, so now layers of the wall, so we discuss. So now I like to give you the idea about the physiology. Physiology means function. I already discussed over here, so you're gonna get it. If you know this physiology, so then you will better understand incontinence of the urine. What is incontinence means? Incontinence means that somebody cannot hold the urine. Cannot hold. So now, physiology. Physiology means function. What does the bladder do? Bladder store the urine. Then void helps in voiding the urine. Voiding means what? Make it out. This voiding function is involuntary and voluntary. What is involuntary? Means it is beyond my control. And voluntary means with my control. Okay, so now let me give you the idea. Say, this is bladder and this is urethra. This is bladder wall. And the bladder wall has a middle layer, it's a detrusor muscle. Okay, I just draw a little. This detrusor muscle is making two sphincter. Detrusor muscle is making two sphincter. This is inner sphincter and this is outer. This is involuntary and this is voluntary. Okay? So now, just give me the idea. Okay, you draw first, then I will give a very good tips actually how we do voiding. Okay, so now give me the idea. When say example, say this is 600 cc. 600 cc or 600 milliliter of urine. So don't you think I need to go bathroom? Yes, this is enough. So now what happened? I feel like I need to go. So then there is a trigon area, there's a nerve endings. They got under pressure, they get excited. They feel like, okay, it's now time to contract the bladder. So now, when the bladder will be contracted, the bladder will give the pressure towards the urine, right? So now pressure goes up. So then what happened? The gate must be open, right? Keep that in mind. The pressure that is sympathetic tone, because autonomic nervous system controls the voiding. Autonomic, same as the heart, lungs. Autonomic nervous system has sympathetic tone and parasympathetic tone. Sympathetic tone causes contraction of wall. Contraction of wall. And parasympathetic here parasympathetic tone opens the sphincter. Opens the sphincter. Which sphincter? Inner or outer?
The inner.
Inner. Open the sphincter, inner. So this is during the act of voiding. What happened? Sympathetic contracts and parasympathetic in the sphincter, it opens. Okay? So now, when it opens, the internal sphincter will open. Then you will really feel urge, I need to go. Just understand, when the sympathetic is contracting, if the gate does not open, what's going to happen? Patient will you will see some prostate gland enlargement patient, they cannot void, they are jumping like that. Okay? So now, during the contraction, the wall will be contracted, gate will be open. You got it? So now, during the relaxation, means it is the time to fill in. Urine is coming through the ureter into the bladder. So then what happened? When the sympathetic tone does not contract, sympathetic tone will relax the bladder. During fill in. That means urine is coming into the bladder and the bladder is getting relaxed, is giving the accommodation. At that time, the gate should be open or close?
Close.
Close. So that time, the parasympathetic will close the gate. So this coordination, what is this coordination? When sympathetic will contract, gate must be open. When sympathetic does not contract, relaxation time, gate must be closed. If this is imbalanced, we call it autonomic bladder. Autonomic bladder. Who has the autonomic bladder? Those who have the psychologically upset, psychiatric patient, or paralyzed. That's why they gave the catheter. Otherwise, they will continuously urination. There will be no control, constantly diaper or catheter. So, sometimes you will get the patient to evaluate patient has incontinence or not. Let me draw that diagram, then you will see. If somebody says, can you check the bladder and urethra for the female, is it autonomic bladder or not? So first of all, you have bladder must be full. This is uterus and the bladder is here. And urethra is right there. You need to know this diagram. So this is bladder. So this is uterus, this is bladder, this is vagina. You need to know that urethra is on the anterior wall of the vagina. And now, normally the urethra is closed. Normally the urethra is collapsed. I am showing the female urethra. But if you look at here, during your sonography, you will see this is urine, it's dark, right? The water, so an anechoic area. Then if you see the urethra is getting open and closed again and again. Urethra is getting one time open, one time closed, constantly. When it is open, the urine rush. When it is closed, there is no urine. If you see it is opening and closing, so this is incontinence. So one time you will see the urine is coming here and there is no urine. That is, if you record it, then doctor will say there is an incontinence of the urine. Sometimes you will see the if the pelvic muscles are weak, so due to multiple labor, so the female get lost of this control. Okay, so this is important. We need to know it. And what is this organ? What is this intestine? This is rectum. This relationship is very important. Okay, I'm going to little modify the rectum and the posterior wall of the vagina. Are closed. So now, how many openings are here? How many openings? Three. So most posterior is the anus. In the middle, vagina, and anterior, urethra. So now it can give you the idea why the woman has more bladder infection. Because the germs, if you don't maintain the hygiene, germs can easily go into the urethra, and retrograde movement, it goes to the bladder. Okay, so you understood the physiology. So now let's talk about the pathology. Pathology of bladder. As I told you before, bladder has wall and bladder has lumen. Lumen contains urine. And this just give me the idea that if bladder has a pathology, what could be happen to the bladder wall? First of all, it could be infection. We call it cystitis. When there will be cystitis, means it is the infection of the wall of the bladder. Then what going to happen? In cystitis, wall will be thickened. Wall will be thickened. That means it will be greater than 3 millimeter. It could be localized or it could be diffuse. Diffuse means all over. And hypervascular. The wall will be hazy. What will be the symptom of cystitis? Sign symptoms.
Fever.
Patient will have fever,
High blood cells.
pain, then increased frequency, scanty urine formation. Patient may also complain burning during voiding. Sometimes you might see blood in the urine. Okay? And urine color, smell, color will be hazy. It depends on the ingredient. Smell could be bad smell. Okay, all those things will happen, and if you do the urine analysis, then you will see morphological change, chemical change, and microscopical change. Okay, so now good thing is that prognosis is good. Why prognosis is good? Because can be treated by antibiotic. By antibiotic. And patient has to be compliant, otherwise it may turn into chronic cystitis. You got it? Good. So this is in the wall. One is infection. Now, so cystitis. Now in the wall, what else it could be? Common sense. There might be a polyp. Right? What is the polyp? Polyp is, say if this is the bladder, so this is a polyp inside. So this is polyp. So polyp can cause thickening of the wall. There might be a polyp not pedunculated. Polyp could be like this, cuboid polyp. So this is called It is a polyp that has a pedicle. What is the pedicle? This is pedicle. Then what is my importance? No, pedicle means one end is free, this is free end, another end is attached with the wall, right? So now if you click the color, then what are you going to see? The pedicle has the flow of coloring. What does it mean? The blood supply is there, feeding artery and venous drainage. So this is polyp. How do you know this is polyp, not the stone?
It's attached.
It is attached one end and one end is free, right? What else? The
Shadowing.
polyp is homogeneous. What else? Medium level echo.
No shadowing.
Yes, medium echo, no shadowing, and pedicle with blood vessels. Okay, so that's it. Then you will see polyp. What else other than polyp? Tumor. There might be a tumor. Okay? Benign is very few, and malignant. What is the most common malignant tumor? Transitional cell epithelial. Transitional epithelial cell carcinoma. Transitional epithelial cells CA. Carcinoma. Okay? And other day I discussed about the transitional cell epithelial carcinoma. If you see this carcinoma, you in the bladder, if this is the bladder you see, then you will see multiple sites. There is a hyperechoic, heterogeneous, necrotic, complex mass. This is in the bladder. Then you need to check ureter. You might get the same kind of cancer, same kind of sono images in the ureter. Then you need to look in the renal pelvis. Then you might see a cancer, transitional cell epithelial cancer is in the pelvis, because pelvis, ureter, bladder all have transitional cell epithelium. So if there is a transitional cell epithelium, so then what would be the complaint? Blood and blood clot. In urine. You can see blood clot attached with the wall or floating in the urine. Okay, and there is no shadow and non-shadowing. So, history of blood, passing of blood or blood clot in the urine, and sonographically you will see It is whether it is attached with the wall or floating. Some blood clot is old, you will see organized, is echogenic, some are not. But they are complex looking heterogeneous mass, non-shadowing. Okay, so that's the way we can differentiate. So then I will talk about the, what is this called? Oh, diverticulum. Let me clean this part. Bladder wall may have diverticulum. What is diverticulum? This is a big challenge. Diverticulum is an external pouch of the bladder. It could be congenital weakness of the wall or it could be acquired. What is acquired means? There is something pathology is tough to void. So patient is doing so then what happened? The bladder wall will be thickened first, then weaker. So so this is a bladder, I'm just showing you, this is a normal bladder in transverse view, and if you see this bladder wall, there's outpouching on this side, or this side. Then you have to say, what is this? This is filled with urine. This is urine. This is urine too. Now look at here. I saw the diverticulum, same size as bladder. How big is it? You know what is the major problem here? During the act of voiding, when the bladder contracts, you might see this part of the bladder never gets contraction and urine is always there. This is stagnation. Of urine. If the urine is stagnant over there, what can happen? Sedimentation. Sedimentation forms stones or infection. If somebody develops chronic cystitis, please check the bladder wall. There might be a pouch. Patient fail to void the urine completely. It could be singular, it could be multiple. So this is diverticulum. And the next one is ureterosil in the wall. Ureterosil. I discussed it before. So ureterosil means, so when the ureter